Hi, my name is Abby Dumes. My pronouns are she, her. I'm a white woman with a purple and blue floral print top. I've got bird-shaped turquoise earrings and brown hair in a braid. Behind me to my left shoulder is a red frame painting, and to my right are bookshelves.
And I am Lisa McCorkell. I use she, her pronouns. I am a white woman with brown hair that's down. I'm wearing a white and black floral print shirt, and my background is blurred out, but you can see a little bit of orange in the background.
Lisa, thank you so much for being here and being willing to share your story with the Global Feminisms Project. I'm going to quickly introduce you and then we'll launch into our questions. Lisa McCorkell is the co-founder of the Patient-Led Research Collaborative, or PLRC, a group of people with long COVID who conduct research on long COVID. She has presented PLRC's work to Congress, NIH, CDC, the President's COVID-19 Health Equity Task Force, and more, and has co-authored several research papers and chapters on long COVID. She is a policy expert with a background in social safety net, public health, labor policy, advocacy, writing, and research. She has a master's of public policy from UC Berkeley and a Bachelor of Arts in political science from UCLA. So I think we'll start with where your story begins. If you think about where you are today, we'd like to hear a little bit about how you would depict the journey that brought you to where you are now.
Sure. Yeah. So I think kind of every step of my life has really brought me to this point, which makes sense. But I never would have guessed that this is where I would end up as the co-founder of a patient-led research organization on long COVID, mainly because COVID wasn't a thing when before 2 years ago. But
Exactly.
I'd say, yeah, I can just start from the beginning.
Sure.
I think a lot of what my background really stems from is from both my personal and professional experiences. So when I was 12 years old, I was diagnosed with celiac disease. I was very active at that time, even for 12, on discussion forums on celiac and kind of how to adjust to a gluten-free lifestyle. And really got a lot of support out of those forums. My mom was diagnosed with multiple sclerosis around that time as well, and went on disability, and just generally, had a lot of medical issues, chronic illnesses, a lot of unexplained chronic illnesses in my family. So that's kind of, I think, the backdrop personally. And then I went to college. Initially, I was interested in neuroscience and kind of using my skills in science and biology, but decided to major in political science, mainly because I was really interested in how politics impacted people's day-to-day lives. I had seen how policies and politics impacted my mom's ability to get on disability benefits and just our various access to different benefits. My first job out of college was as a financial counselor. I helped people with their budgets and credit scores. And then I went to work at a nonprofit employment law center that focused on gender and racial equality in the workplace, as well as stable scheduling for hourly workers. So all of that experience kind of really showed me and continued to show the impact of policies on people's lives and ability to have equal and equitable outcomes. But decided from there I really wanted to do more with that, so went to graduate school to get my master's in public policy. While I was there, I took a few health equity classes kind of just by chance. I was just interested in the topic of social determinants of health, but really wasn't focusing on health policy itself. I was more a generalist and kind of interested in a lot of different areas of policy. So I graduated in May of 2020, and I got COVID in March of 2020. So this was very early on, right before the lockdowns is when I had my first symptoms. And at that point, I joined the Body Politic COVID-19 support group about a month after I started experiencing symptoms, mainly because it was, at that time, there wasn't much discussion of these prolonged symptoms of COVID. It was, you're either hospitalized, you have a very severe course of illness, or if you have a mild version, you recover within 2 weeks. So once I realized, that wasn't my personal health journey, and I was having these prolonged symptoms and actually feeling a lot worse as time went on, joined the support group and founded Patient-Led Research Collaborative from that. I can talk a little bit about kind of how we've come to be from there, if that would be useful.
Yeah, that would be great. Let's keep talking about your work with the PLRC.
Yeah, so we all came together in April of 2020. All joined the Body Politic support group, and we saw this need. Everyone was sharing their experiences and these prolonged symptoms that, again, the government and media, no one was really talking about, and sharing different treatments that they're trying and different research they're coming across. And we saw this need to compile that information and see if there was any trends occurring, if people are experiencing the same symptoms, and just really try to compile all this information. So a few of us who had some kind of research backgrounds came together, put together a survey, and produced the first research on long COVID. We did it in less than a month, put out the survey, and then did a very quick analysis and did a Google Doc where we put this report, and it was published May 11th of 2020. And that was really the birth of Patient-Led Research Collaborative, unbeknownst to us that it would be where it's at now today. From that report, we started getting some media attention on what long COVID was, and we connected with the CDC and a few other government organizations that wanted to hear more about the experience, and really started recognizing this as like, oh, this could be an issue if there's this big subset of people that are experiencing these prolonged symptoms. Mm-hmm. And of course, we know that, really post-viral illness and long COVID isn't new. It's just, all post-viral illnesses have existed since really viruses have existed. But unfortunately, at the time, people with post-viral illness were not being listened to, and their warnings about this possibility of long COVID weren't heeded. But so from there, we got a lot of interest from different researchers and from different government orgs, trying to learn more about the long COVID experience and trying to hear what patients were experiencing. So we did a follow-up survey that was more expansive. We put a preprint of that up in December of 2020, and it was published in the Lancet's eClinical Medicine in July of 2021. And that documented the over 200 symptoms of long COVID and the trajectory of symptoms over 7 months of illness at the time. And from there, we just, continued to do various research projects, consulting on long COVID research as it started popping up and researchers started paying attention to it, started advocating for policies that support people with long COVID and all post-viral illnesses. And in terms of my interaction with Patient-Led Research Collaborative and my involvement, I was doing all of that work on the side. I had a full-time job working on SNAP policy in California. And so anything I was able to volunteer was what I was doing with PLRC until May of this year, we received funding that enabled me to go full-time with Patient-Led Research Collaborative, which is very
Wow.
exciting.
Congratulations.
Thank you.
Big milestone.
Yeah, so now we're scaling up. We have a few new projects that we're launching. And yeah, just more and more attention is being paid to long COVID. There's still a lot of narratives that we're, having to contradict that are misinformation, and but we've come a long way in 2 years, and I think a lot of it has to do with our early work, as well as many of the other patient-led organizations that have come out of long COVID.
You mentioned that you initially started sort of under the umbrella of body politic. At what point did you become your own entity? And then maybe describe a little bit, as you mentioned, some of the collaboration between and among groups.
Yeah, what's interesting is that even now we still work within the body politics Slack support group. So all of our work is done pretty much asynchronously through the body politics Slack group.
I see.
But we became our own, I'd say, kind of group once we started receiving some funding for the research specific group. So we started an LLC, and that was probably in like July or August of 2020. So still fairly early on.
Yeah, pretty early on.
Most of the advocacy that we do is in partnership with Body Politic. We really try to, any of the policy proposals, or when we're identifying needs of the community, it's sourced from the support group. And we have very close collaborations with many of the other advocacy groups that we've kind of just found each other and are trying to support each other as best we can.
That's really helpful. Thank you. I guess we'll move on to thinking about this work in the context of feminism. And if we could just pick your brain a bit about how you understand the term feminism, what it means to your work, if it means anything to your work, if you consider yourself a feminist, mapping that out would be helpful.
Sure. Yeah. So, how I understand the term feminism is largely, I think, that by definition, equal rights and opportunities for all genders, but also equity within genders. So, within different races and ethnicities, within different disability statuses. In my view, a feminist is not necessarily someone who wants equal rights between white able-bodied women and white able-bodied men. It's more intersectional than that, and particularly within an illness like long COVID and other post-viral illnesses that do seem to impact women and transgender people more than men. Feminism has really played a critical role. Even within our group, Patient-Led Research Collaborative, we're it's co-founded and leadership is all women. So it is very important to us, and we take that very seriously, and have seen the severe downsides of a lack of feminism and a lack of focus on really equity and a lack of focus on women in the medical field. So an example of that is the role of reproductive health and sex hormones is severely lacking in any research on long COVID. We are not seeing, if we see surveys, they're not asking about menstrual cycle changes or any type of menstrual symptoms, but that's really one of the biggest things that we're seeing people experience. That's one of my main symptoms. I developed premenstrual dysphoric disorder after long COVID. That is never asked about. A lot of people are experiencing perimenopause. They're having difficulties becoming pregnant. These are all things that are severely understudied, and So it's critical to, in this work, be a feminist, and in order to ensure that research is representative and that it's actually capturing people's experiences. So yes, I definitely consider myself a feminist, and we try to incorporate intersectional feminism in our work, and particularly our advocacy, as much as possible.
Thank you so much. So you mentioned in the beginning a little bit about your own symptomatic experience, and then just a little bit now. Would you mind sharing a little bit more about that journey and maybe experiences you had in a clinical setting, thinking about gender, and how gender impacts clinical experiences and experiences with long COVID more generally?
Yes, absolutely. So I first got sick March 14th, 2020, had initially mild illness, but within about 3 to 4 weeks into my illness, I was unable to walk a block without having severe shortness of breath, being very fatigued, bedbound for the rest of the day. And this was, pre-COVID. I was a half marathon runner. This was very different than what I had experienced before. At the time, the care that I received, it was, I wouldn't say I was dismissed at that time. It was more just like my providers didn't know what was happening, but they were very clear with the fact that they didn't know and that this was all very new.
And did you have a positive test at the time? I know that can be a limiting factor.
Right. Yeah. No, I wasn't able to get a test because I didn't have a fever, and you needed to have cough, shortness of breath, and fever in order to get a test.
I see.
So at the time, my provider had clinically diagnosed me with COVID, but I wasn't able to get a test. But then that, kind of bit me later on.
Right.
And I started, I would have a lot of brain fog, fatigue, these periods of shortness of breath and tachycardia. But after a couple months, I started feeling a little better. I felt like I was doing a very, very slow recovery. But then in August of 2020, I pushed myself more than I had before. I did this exercise class that was way more than what I had done in the past. And I had this severe tachycardia, palpitations, shortness of breath, to the point where I really felt like, something could be wrong with my heart, or, something's definitely wrong. So I went to the ER, and the provider there not only said that I never had COVID, but he also said that my symptoms were anxiety and nothing else, but didn't even then give me treatment for the anxiety that he diagnosed me with. He just sent me home and said, you need to just calm down, and then you will, have your symptoms will improve. That didn't happen, unsurprisingly. I continued to have symptoms, but what that did result in was me being very skeptical to this day about seeking medical care. It is now a fairly terrifying experience going to a provider when you know that there's the option of them dismissing you and not taking your concerns seriously. And also, especially him saying I never had COVID, just completely dismissing my experience, and something I knew to be true. And that's unfortunately something that's not a unique experience. I think that the vast majority of people with long COVID, particularly women of color, are even to this day experiencing this dismissal because of, I think it's more lack of awareness of these symptoms and a lack of awareness of post-viral illness generally. But the reason there is that lack of awareness is because it's largely women that are impacted. And so it's been understudied, it's been historically dismissed. And yeah, so it's, I mean, that's one of the biggest fights that we have in long COVID, is just this recognition, this need for recognition that our symptoms are real, that we deserve treatment, that we deserve proper care. And also that providers, you know, if you don't know what's going on, it's okay to say, I don't know. You don't need to give a diagnosis, you know, a mental health diagnosis if it's not, if you know, haven't done the proper screenings to get to that diagnosis. Yeah, I'll pause there.
Really helpful. So that was August 2020. What happened after that?
Yeah, so that's when I really turned back to the support groups and going online for information. And I recognized that, oh, what might actually be happening right now is POTS, a POTS attack, or postural orthostatic tachycardia syndrome, that seemed to be very, you know, a lot of people with long COVID were having those same symptoms, getting that diagnosis. It's often onset by a virus. And so I did kind of an at-home test where you stand up and see how much your heart rate goes up within a certain amount of time. And I realized, like, oh, that might be it. And so I kind of had a self-diagnosis at that point, and tried to learn to manage it based off of people's tips and just what they were sharing online. And then it took another few months for me to feel comfortable going back to a provider. And I tried to find a provider that was a woman and who had a bit of experience in POTS and some of the other post-viral illnesses. And so once I was able to go to her, she did an official test and gave me a POTS diagnosis. And it took, you know, even at that point, I hadn't identified the PMDD, or premenstrual dysphoric disorder, symptoms that I was describing. And I was never asked about those symptoms by any provider, any type of menstrual changes or mood changes around my period. So it took me longer to identify this kind of pattern that I was experiencing of worsening symptoms a week before my period, particularly very severe mood symptoms. And so that took another year, I would say, to get that diagnosis. But from there, my symptoms kind of had a relapsing, I don't want to say remitting because I never went back to full remission, but just more stabilizing, kind of back and forth until I got the second COVID vaccine, which actually helped to improve my symptoms. And I went to a higher baseline. I'm still not back to, you know, before COVID.
Pre-March 2020.
Yeah. But have been fairly improved since then. I'd say I still deal with POTS symptoms, but they're, you know, often pretty well managed. And then I'm still trying to figure out the PMDD and what helps with that. So yeah, it's interesting. I mean, I'm able to have a full-time job. Probably wouldn't if it was in person. That would be very tough for me. But I have a very mild version of long COVID, and it still impacts, you know, my hour to hour. So it's, yeah, long COVID can really be extremely severe. I'm very grateful for the amount of, you know, health that I have now, and trying to use that to help advocate for other people.
Yeah, that's really interesting. So do you have strategies, given the extent to which it still impacts your day, do you have strategies to minimize that? I know resting and pacing have been really important for some. Is that something that you're mindful of throughout the day?
Yes, definitely resting and pacing. Try not to have too much going on in one day and having breaks throughout. If I feel, if I start feeling symptoms coming on, which it is interesting, I can very easily tell when they're coming. Just trying to, take a break immediately and do radical rest.
Oh, I like that,
I
radical
always,
rest. Have you used that phrase
yeah,
before? Is that a term that you use?
yeah, it's important to do, because I think a lot
Right,
of people think resting is, you can watch TV, you can read, you can do
right.
that type of stuff, but really what's needed is like no sensory input and just very radically like just laying down and not doing anything, and prioritizing that.
Yeah, that seems like a really important distinction.
Yeah,
Helps frame it, I think.
yeah. But yeah, I always have a big thing of water next to me, which is helpful for POTS, is increasing fluid and salt intake. And so those are the biggest things that I do, is trying to manage salt through those types of, manage POTS through lifestyle modifications. And then just, pacing is a huge one. That's so important to do.
So I think we talked a little bit in the beginning about collaboration between and among long COVID groups. Has there been work internationally in the context of your group? And if so, what does that international, transnational collaboration look like?
Yeah, so we have long COVID groups have popped up in many countries, and we try to maintain relationships with all of them. Body politic itself is international, so anyone from any country can join. Our organization, we have members from I think 10 countries is what our membership is from. We have a total of 45 volunteers.
Wow.
I think over 10 countries or so. And yeah, so there is long COVID is impacting every country. It impacts, 10 to 30% of COVID cases. So it has really big impacts across the world. And where we've seen a lot of our partnerships is from when we are trying to distribute our survey. We've tried really hard to partner with other countries' groups so that they can share that with their membership. We had our last survey translated into I think it was 16 languages, really trying to get more diverse respondents and trying to capture the experience of people in other countries. And yeah, I think it's really important to see the reaction in different countries of government's response to long COVID, of how people if people have access to adequate care. And so that's all been really important for us, and a lot of our work that we're starting with our new funding is really trying to focus on that even more, to focus on the international aspect more, because so much research generally, but long COVID, from what we've seen, has been focused on US, and it's very Eurocentric as well.
Right.
So trying to more look at what's going on in other countries, and how can we ensure that if there are treatments that become available, that they'll be available to everyone in the world. That's a global thing that's accessible. So it is something we're trying to work with more, and that will include a lot of more partnerships with some of the orgs in other countries.
Have you seen any of the gendered patterns we were talking about in the US also play out in other settings? Are there similarities or differences? And can you trace a few of those? Or I should say gendered and intersectional.
Yeah, I definitely similar, dismissive type of experiences from providers that, we definitely see that in Europe, and we have a large contingent in the UK. And yeah, from the experiences that we've heard from other countries, like more low and middle income countries, it seems to be playing out there as well. I think, it sounds like probably to a more severe degree, but that's part of what one of the studies that we are going to launch is a quality of life survey for people with long COVID in a low to middle income country. So really looking at that question, looking at people's experiences and in receiving care and their symptoms, and if there's different types of symptoms and severity across genders, across income strata, all of that.
Wow, that seems like such an important contribution and a really understudied dimension. Has that survey already launched, or is it sort of in the works?
In the works, yeah. Hopefully in the next few months we'll get it launched.
Wow, I'll be really curious to see, at least in the the social science work on chronic illness. It's a very understudied part of the literature, and so it'll be really helpful to see what you find out. Maybe we can talk a little bit about sort of personal and organizational sort of future orientations. So sort of where you see things going from here for you, even down to how you sort of navigate the present and the future with risk management. Having experienced this, does it change the way that you are navigating your life in a continued pandemic world? And maybe some more of the projects that PLRC might take on in the future?
Yeah, it's a tough question, I think, because as PLRC, we formed seemingly kind of out of thin air, like kind of just by chance, and didn't have a strategy from the beginning of like, we're building an organization that's going to be sustainable for years. And so we've kind of just been going based off of opportunities that have arisen and this, dire need for this type of work. The current funding we have is for a year. So it's, unclear beyond that, but we know that long COVID's not going away. More research will be needed, more advocacy will be needed. So, potentially, likely we'll still be around and be working on other projects. But yeah, I mean, right now, so the projects that we're standing up, it's the low to middle income country quality of life I talked about. Our biggest one is a research fund. So we're actually re-granting some of the funds that we're getting to, we're going to identify projects that are really hopefully on the cutting edge of finding out what is actually behind long COVID and other post-viral illnesses, and what are some viable treatments for that. So we're going to have a round of accepting proposals, and we have a patient panel that we formed that is just really incredible patients in that either have long COVID or another illness like ME/CFS, which is myalgic encephalomyelitis or chronic fatigue syndrome, POTS, which I mentioned earlier, which is what I have, and other illnesses. So people with the lived experience of one of these illnesses, as well as a professional experience in some type of research area. So we gathered this patient panel, and they'll help us identify which projects to fund that really have the most promise in helping us find answers. So we're very excited about that. And another one that we're looking at that we think is very important for informing pandemic policy in the future is looking at reinfections and the role that those play on both people that currently have long COVID. How does getting reinfected with COVID impact their symptoms? But also, if you had COVID, did not develop long COVID, and then are reinfected, what are your chances of developing long COVID after that? And we're seeing that there's an increased chance, which I think is not, clearly has not been considered in current pandemic policy. When we're thinking through the possibility of, COVID being normalized, quote unquote, or this like return to normal, it's this assumption that people will just keep getting reinfected and we'll have to deal with several reinfections a year without considering the very real possibility that a large proportion of those people will get long COVID. So, trying to measure that and just figure out what kind of impact reinfections are going to play, I think will be hugely important for the future. So those are some of the projects that we're starting, and I imagine that there'll be more hypotheses that we want to tackle in just the next few months, or in the next year. But yeah, it's kind of a big question mark. I think we've been very reactive as an organization, more so than planning it out, because ideally we wouldn't need to exist as an org. So we're not planning for long-term sustainability, although it might be smart at this point to do so, unfortunately.
So with that information, how do you process that in your own personal life, navigating sort of risk-benefit analysis of living in a pandemic world? Are you more cautious, having been through what you've experienced, and take greater steps to avoid reinfection, or has it framed decisions in a different way?
Yeah, absolutely. I mean, I would say, I'm definitely the more cautious of my friends outside of, the long COVID community. And yeah, I think like seeing it firsthand, experiencing it firsthand, can really make people realize what the risks are. And so yeah, I have not returned to normal, and that's not just because my body hasn't returned to normal. It's just that it's not. It really is not worth the risk to myself nor other disabled people that are at risk if I do decide to go into public unmasked, or do some riskier activities. So yeah, I limit my travel. I stay masked in public. I don't do indoor dining, and I really don't see much of that changing anytime soon. I think that this is, my new normal, and I will always be, kind of at higher risk now. And yeah, the removal of the mask mandates, I think in particular was more of what has had an impact on my life, because I used to feel like fairly comfortable going to the grocery store and taking care of my day-to-day needs. And now that becomes a fairly risky situation, even if I'm masked, the fact that a lot of people around me are not during a surge is very risky. So it's definitely, this experience has absolutely, I'm sure, changed my risk assessment and, what I'm willing to do to avoid a reinfection, because I know what the potential consequences are.
That's really illuminating. I want to go back to the idea of radical rest and situate it within sort of societal expectations of work and rest, and what you think might be some of the equity limitations in a solution to feeling unwell that might not fit with societal expectations.
Yeah, that's a great question and a huge question. In our survey, we found that 2/3 of our respondents were either completely unable to work or had to reduce their hours. That I think that a lot of it, based off of from what we've heard from patients and what we've experienced ourselves, is not that people are actually completely unable to work, but they're not receiving the accommodations that they need to be able to work in our current society, right? And the really harsh demands and very strict time frame that society has set up work. I think that's one of the best things about PLRC is that we communicate largely asynchronously. So whenever, we try to limit meetings as much as possible, so people don't have to be, feeling well and be expected to feel well enough for a phone call all at the same time. So you participate when you're able to, having long deadlines, not having short turnaround times, allowing people to work in the middle of the night if they need to, and just really focusing on what are people's access needs in order to participate and trying to meet those as best as possible. And so that's how we've run our organization, and we have done a lot over the last 2 years, right? It's not that, I think we have created this model of work that is where people can contribute when they're able to. And, we have this really amazing work product, and we're able to make a lot of change in the world, but it's on a different timeline and using different structures than what most of the capitalist society adheres to and thinks is required. And yeah, I mean, we'll have a lot of our volunteers will go through relapses, will be crashed for weeks. And we never want people to work through that. Health is the priority, right? Like that's the priority for us is people's well-being. And unfortunately, that's not the priority of most of society. It's not well-being, it's productivity. And for some reason, there's a disconnect between seeing that with well-being, you then get productivity. And yeah, so I think, as more people develop long COVID, unfortunately, it's just going to be necessary for employers to be more accommodating. So it's, it's kind of a, there's a benefit to all of this, if I can say it's a benefit. But right now we're looking at 7.5% of all adults in the US have long COVID right now. That's a huge percentage of working people that will need these accommodations, or else, we're going to have a significant portion of our workforce missing. So yeah, I think getting through that radical rest is important, should be part of people's day-to-day work schedule if they need
Mhm.
it.
Mhm.
Is just going to be really crucial for our economy to stay afloat, for people to, continue to take care of themselves financially, take care of their families. Um, it's just understanding that concept and understanding its benefit is going to be really, really critical.
Can you think of anything else on a structural level that might help meet those needs? It seems like enhanced and increased flexibility and accommodations would be hugely beneficial. Is there anything else that we could add to that list?
Um,
I mean, I know a lot of people mention paid time off,
yes.
a
Yeah,
larger
absolutely pay
healthcare
time
safety
off.
net, which it's your
Yeah.
expertise.
Pay time off is critical even for not developing long COVID. Too many people are being pushed back into work
Mm,
after getting
mhm,
COVID,
mhm,
not getting the adequate rest that they need in those very crucial early stages.
mhm,
We've seen that people who were able to rest those first 2 weeks because they had paid time off are less likely to develop long COVID. So that's a huge issue, is the fact that we don't have universal paid time off. And even if you do have paid time off, it's usually inadequate.
mhm, mhm.
Um, yeah, so that ability to take time off at the beginning of the illness, but even throughout, not being at risk of losing your job if you need to take a month off to really focus on that resting and, trying to recover, and then doing a phased return where then you figure out what
Mm,
accommodations work best for you.
yeah, interesting. I like that phased return.
Um, I think that, those types of things are really important. Obviously things like Medicare for all and, equal access to healthcare is
Mhm,
critical, and something that we're seeing, a severe lack of, not just, people not having access to health insurance, but even when you do have access to health insurance, there's not enough providers focusing on long COVID,
mhm,
who are well trained and educated in post-viral illness. Like the best specialists have a year-long waiting list, and that's just not acceptable,
mhm.
when but it makes sense when there's so many millions of people needing care all at once.
Right. Yeah, big bottleneck. Is there anything I didn't, as we're wrapping up, is there anything I didn't get to that you wanted to make sure that we talked about or that we mentioned?
Um, I kind of mentioned this a little bit, but I think with all of the wins and progress that we've made as, people with long COVID in a very short amount of time, we have, as much as we still need in the last 2 years, we have made significant progress. None of it would have been possible without all of the activists that came before us. And that
Mm,
includes, particularly post-viral illness activists, but, even before that and during that, HIV/AIDS activism, and, all of the wins that we've received over the last several decades in feminism and in, um, all of the various intersectional identities, that people with long COVID have. It's, that's all been critical to getting us to this stage. There's so much work left to be done, but,
mhm,
I think it'd be naive to say that and inappropriate to say that, long COVID patient advocates did all this on our own, because there's absolutely no way that we did. We got this opportunity because of how big of a scale this problem is, but also because people paved the way before us that gave us access to these rooms and gave us access to, this type of being able to do this type of work.
That's really moving and powerful, and I'm glad that it seems like a good note to end on, to come full circle. We started talking about what brought us here, and in some ways we've identified what brought us here collectively. So I think that's a really a nice way to end. It has been such a pleasure to talk to you, and an honor to interview you, and I'm grateful that you were willing to share your story, and we're glad to have it as part of the Global Feminisms Project. So thanks again.
Thank you so much. I've appreciated being part of this.
Of course.